Hello, Aggrey Semeere from Infectious Disease Institute, and I thank you for this opportunity to talk about how we assess feasibility of using rapid case ascertainment to evaluate KS in IDEA East Africa. Important descriptive and analytic questions remain unanswered regarding KS, and among the descriptive is what stage of disease at a diagnosis among the patients developing KS is seen among these patients developing KS in ART era, and then what is the prognosis for these patients in this ART era? Analytically, why do these patients develop KS in the first place, even with adequate viral suppression? And who among them can benefit from ART treatment alone? Answering them needs a systematic identification and detailed characterization of these patients. And the process, this is a process that's called rapid case ascertainment. Rapid case ascertainment is not unique to cancer. It's been around since the 1920s, formally operationalized in the 1970s in many cancer registries in the US to offer a free service. During rapid case ascertainment, you can collect data for clinical characterization and biochemical characterization, and amongst them, you can also assemble case control studies for etiologic research and observational studies to study prognosis and survival. So we set out to assess feasibility of implementing RCA and thereafter describe the clinical and characteristics of the patients who develop KS. We did this within IDEA East Africa sites at Ampath in Kenya, in Masaka, and in Barara. We targeted newly suspected patients diagnosed with KS, and these were above 18 years at all these sites. Ampath starting in 2016, and for the other two sites starting in 2018. We identified patients through mostly clinical and laboratory processes. That's the medical wards, dermatology wards. And we mapped processes like electronic database queries, searches of the ward records, dermatology records, and upon identifying individuals, set out to find them to evaluate them for RCA. And when we actually did find these individuals, we took this opportunity to take a good history, look at history of treatments, a detailed examination, including photography, eventually collecting blood, saliva samples, sometimes even performing a biopsy. Since for the study of between July 2016 and April 2019, we have seen 596 individuals, and amongst them, we've been found that 169 were ineligible due to many reasons, but performed RCA on 289 of the 427 eligible. We failed to perform RCA for mostly those who died early and some who were unreachable with the contact information we had. How fast we were able to reach them, accounting for death as a competing event in this analysis, as of 30th April 2019, RCA was done on 64% of these patients by 3 months. And what would these patients look like? Most of them were male, and 88% of them, most of them on ART, and say over 70% of them had a viral load less than 1,000, and 90% had advanced disease. So what does this mean? In summary, we've shown that RCA can be performed for 2/3 of the patients within 90 days. However, almost all these patients had advanced disease, and failing to perform RCA was due to early death or poor contact information that we had. So for the future, we suggest that RCA is feasible in sub-Saharan Africa, but you have to have better information and more robust processes to identify patients. If it's feasible for all cancers, and if performed optimally, you can answer all these questions that are pending. And we have created a platform where this is feasible. This work wouldn't have been possible without all these collaborators to whom we are very grateful. Thank you.